Welcome, thank you for coming back. It's actually pretty well the same groups of people that are watching these videos most days, so there's not many outsiders watching them, so it's mostly just you and me, so I appreciate you coming back. Now I'm going to start off with a bit of an update on New Zealand today, then the United States, and then we're going to look at what is starting to amount to, I believe now, a second wave in Europe. Throughout Europe, cases are increasing in pretty well every European country. And then I've had so much feedback, which I really appreciate, on the reason why that the mortality and morbidity seem to be much lower in sub-Saharan Africa than in other parts of the world. Now we're hoping this is genuine data. And I've had lots of possible reasons sent in, so I've put a few of these together and we'll have a bit of a talk about that and try and work out what it could be, because we need to learn what is being done right, assuming the figures are right in sub-Saharan Africa, what is being done right there, so we can transfer that to our Western way of life. So probably a lot for us to learn there. So that's the kind of plan for today. So let's dive straight in with New Zealand. Now, actually, I think I'll just show you the graphic from New Zealand first, because it kind of says it all, really. This is the graph from New Zealand, confirmed and probable cases. So this was their original epidemic here, their part of the pandemic. Then they had 102 days with no community spread, and now we've got a few new cases there, and that's the last one there. The most up-to-date one, as we'll see. So, I mean, to me, that graph just really shows that this pandemic has not gone away. It's still lurking there, even in New Zealand. We'll look at why it might be the case in a minute. So here we are. Now, New Zealand, of course, are way ahead of us in terms of time. So that is actually the data for Saturday. That's today's data. 7 new cases today, because they're ahead of time for Europe and way ahead from the United States. So 13 new cases on Friday, 7 new cases on Saturday. So the Auckland cluster, now I make it at being 36 cases. 1 is hospitalised. Now 2 cases in a town 135 miles away from Auckland. But it seems that these cases have an epidemiological link. So one of the key things when you're looking at new cases are, can these cases be epidemiologically linked to people in the original cluster, in the original outbreak? If they can't, that means it's a new cluster, a new outbreak, or there's been undetected community spread. And it looks like these are epidemiologically linked by the New Zealand-based epidemiologists and trackers of these things. So it's really part of the same cluster, albeit 135 miles away. So that's relatively good news, actually, I think. Now, 83% of contacts of infectious people have been traced within 48 hours. Now, that might sound high, but I must say, given that we've got so few cases, 83% doesn't actually sound too impressive to me. So it sounds good, but they've only got a cluster of 36 to work on. I would have thought they'd do slightly more than that, but that's the figure. At least they're honest and open about it. Auckland to remain locked down for 12 more days. Now, they've been doing genome testing. In other words, they've been looking at the genetics of the particular type of virus that is causing the cluster in Auckland. Now, we know that the virus is mutating all the time and the slight changes to the genetics of the virus. We believe that doesn't massively change the infectivity, how infectious the virus is, how transmissible it is. And we believe it doesn't greatly affect the virulence and pathogenicity of the virus, how likely it is to cause disease. But yet, there's all these things where we can trace the evolution of the virus as it changes genetically slightly over time. And this is called a phylogenetic analysis. And of course, the New Zealand authorities have been doing this. And what they found out is quite interesting. They found out it's not a burning ember. So in other words, it's not a leftover undetected community spread from the original outbreak. So it must not be genetically the same as the virus that caused the original New Zealand spike that we've just looked at. And it's not related to strains of the virus brought in by returnees in quarantine. So there's been some cases in people that are quarantined in New Zealand. That's why they're quarantined, returnees, people with permanent residence in New Zealand, citizens who've been coming back. But the virus is not related to that. So it's not left over, it's not a burning ember. It's not been brought back in by returnees as I'd suspected. Now, 2 days ago, I said I believe that the most likely way that this got back in was through the borders, because we noticed that 63%, was it, I believe, of biosecurity staff at the borders and in the hotels and in the quarantine centres had not been tested. So my money was on that. But the New Zealand authorities are saying, no, it's not imported from returnees. Well, what does that leave? Well, it leaves the possibility that it came to New Zealand in a package, such as frozen foods. So that's now looking the most probable. But there is another possibility. Another possibility is this could have been somehow, the virus could have gone from people to animals in New Zealand. Now it's gone back from animals to people. So there could be a zoonotic reservoir. Now, there's no evidence that that's the case. But if it does turn out to be the case and this virus can hide away in animals, that would be concerning. But there's no evidence that it's the case at the moment. So to me, that means the only way it could have got in, the only way I can see left that it could have got in, is that it came in via cold imports. And we know that a cold store facility in West Auckland there's been several infections. So it looks like the best guess at the moment is this virus got into New Zealand via frozen imported products, probably frozen imported food. And indeed, there's another example of this. There was some chicken found in China that was tested positive for the virus that had been infected in Brazil. But because it was frozen, the virus had been preserved in the frozen chicken from Brazil to China. When the chicken was thawed out in China, the virus was still there. And we know the virus can survive, well, other coronaviruses can survive for at least 2 years frozen, probably longer. And we know that other viruses survive for decades, if not centuries. Who knows, even millennia in frozen conditions, such as the permafrost and in glaciers and things. This is a source of influenza A transmission. What happens is birds can poo on glaciers. Then it's covered over and frozen. And then when that part of the glacier thaws out the next year, the virus can reinfect the birds. So this is known about. So that's a possibility. So frozen transfer looks like being the modality of spread to me, given that this seems to have eliminated pretty well all of the other possibilities, unless, of course, you can think of another possibility. That's not a burning ember. That's not imported from people, carried by people. That's not zoonotic, fresh zoonotic infection. That's not frozen food transfers. Is there a fifth possibility? If you can think of one, do let me know. Now, moving on to the United States. Where are we? There we are. So the United States. Now, this is the CDC information 2 hours ago this morning. This is the New York Times is that one. So the New York Times is showing just very slightly more cases. So 5.2, 5.3 million cases for the New York Times. And just a couple of thousand more deaths for the New York Times. I must say, disappointing that if this is just out of date, that the Centre for Disease Control website is not kept up to date. And the New York Times one seems to be more up to date. And also they might be counting things slightly differently in the New York Times database. The New York Times database does seem to be shaping up nicely. They're collecting data from federal, state and local officials and collating that themselves. Big job. So the discrepancies between the Centre for Disease Control and the New York Times data may well increase. Now, Mr. Robert Trump is the younger brother. I'm pretty sure he's the younger brother of President Trump, and is currently hospitalised, so we wish him well. We don't know why he's hospitalised. The diagnosis hasn't been released, and of course this is entirely proper. This is patient confidentiality. he could have COVID-19, maybe he hasn't got COVID-19. We haven't been informed, and that's entirely up to the family to decide if they want to release that information, of course. Now, testing in the United States, delays in testing in 34 states. Now, obviously, this is so obvious now, everyone knows this, but if testing is delayed more than 3 days, then epidemiologically that does not help to reduce the spread of transmission, because people are most infectious in the first 2, 3, 4 days after they become symptomatic. And if they have to wait a week for the test or 2 weeks for the test result, then it's interesting for them personally, but it doesn't help spread the disease unless people self-isolate after testing. So people who are tested should self-isolate until they get the test result back. But you can understand the frustration if that's taking 2 or 3 weeks. My wife was actually tested last week, and the result came back the next day, which is good. We only had to self-isolate for 24 hours. Thankfully, she was negative. But we self-isolated for the 24 hours, and if it had been a week, we would have self-isolated for the week. If it had been a fortnight, we would have self-isolated for the fortnight. But not everyone's doing that, so this is resulting in more spread, the delay in testing. The combination of the delay in getting the results back, not so much the testing, the delay in getting the results back, the combination of that and impatient human nature means that spread is occurring because of delayed results from testing, which is unfortunate. Now, because of the delay in testing, the American Medical Association wants fast-track testing for people that are symptomatic and people with known exposure. And I must say that does make sense to prioritise testing for these higher risk groups. Now, something else in the news today in the United States, the government scientists. Now, I got this on the new, what was it, NBC News Channel report. And they just said government scientists. I listened to it about 3 times to see if I could find out who it was. And they just said government scientists, and they're developing a strain for challenge testing. Now, what this is, these government scientists in the United States, whoever they are, I'm not saying this is secret. I'm sure it's known. I just don't know. But what they're doing is they're developing a strain of the virus so people can be deliberately infected with that strain of the virus. And I would imagine they're trying to develop a strain of the virus which doesn't make people sick. Now, that's got 2 implications. If there is a transmissible virus that doesn't make people sick, and that's exposed to the general population, then that could build up immunity to the actually pathogenic virus. Virus sort of a rival pandemic, as it were. Now, I don't think they're trying to do that. The unknowns and the risks associated with that would just be too high. But I think what they're trying to do is develop this this COVID-19 virus, which doesn't cause severe disease. So what they can do then is they can vaccinate people with their 2 doses of vaccine or whatever's normal. Then 2, 3, 4 weeks later, inoculate them with this new virus and see if the virus multiplies. This new virus multiplies in the individual. If not, indicating that they're immune. So it looks like they're working on that as an experimental model for the vaccine, because the double-blind randomised controlled trials at the moment on the vaccine that are happening now, what they're actually doing is they are just vaccinating people or giving them an injection of salty water, presumably as the placebo, an inert substance, and then just waiting to see via natural transmission how well these people are protected. This would accelerate the process. And I must say, I do strongly suspect, and I'm not going to name names here, but I do strongly suspect several countries where I have had intimations, shall we say, that people have been vaccinated with experimental vaccines and then deliberately infected or inoculated with the actual COVID-19 virus to see if they are immune to it. And I've got reason to believe that has happened in a few parts of the world. Now, that would not pass ethical approval in Western countries, but it has probably happened in quite a few places. And of course, if this was done, then that could greatly speed up vaccine development, because you would, instead of waiting for people to become naturally infected before you could collect your data, you could actually infect people and then see if they actually develop the illness or not, and that would speed up the experimental testing process. Let's hope that hasn't been done anywhere, because I don't think that is ethical, but it would speed up the process, and that's what it looks like these US government scientists are trying to do, and that does seem reasonable, providing the people that would be given the experimental vaccine and the people that would be given the inactivated live strain of the virus are fully informed and give complete consent to being tested in that way. Now, there's been a much trumpeted report from the Centre of Disease Control in the United States, and it's been reported all over the world for some reason, and I read it a couple of times and really didn't get much out of it at all. Disparity and incidence of COVID-19 amongst underrepresented racial ethnic groups in counties identified as hotspots. Okay, now they call a disparity between two groups 5% or more. So if one group gets 5% more infections, 5% more hospitalizations, 5% more deaths, that counts as a disparity. Fair enough. And we know that people from African American origin, Hispanics, Indigenous First Nation Americans, more likely to become infected, hospitalized, and indeed more likely to die, unfortunately. Experience more severe COVID-19 illness. Now, they collected data from the 5th to the 18th of June. 205 counties, 33 states with hotspots. So fair enough. That covered these 205 counties. In the 33 states, there lived 93 million people. And there was over 500,000 cumulative cases. But racial data was only collected on 27.5 million of the 93.5 million. And there was only a detected 162,000 cases. So that's what, is it third? It's about a third. So racial data is not being collected on the vast majority of people in the United States. Now, this is a major omission. When we're doing epidemiology, studying disease, you want all the information you can. And for the vast majority of counties not to collect data based on race, to me, seems to be a significant omission. So I would suspect I would advise that they start doing so. Then we would have data from 93 million, not from 27 million. Then we'd have data from well over 500,000 cases as opposed to 162,000 cases. The rest, the racial data, is simply not known. So big omission there. But the bottom line of this study seemed to be that 96.2% of those counties had disparities. So, yeah, 96.2% of the counties studied did have racial disparities. And presumably, if that had been carried on to the larger sample, it would have been the same. But of course, we don't know because they didn't collect the racial data. But still, that is a large number. But of course, the criteria for disparity is only 5%, so it's not huge. Although very often, of course, the disparity will be greater than 5%. So, bit of a frustrating read, really. Do read it for yourself. The references are all there. Just click on it. But hard to, it's going on and on and on, and you think, what is this thing actually saying? And by the time you've read it all, they were the only sort of hard figures I could get out of it. Maybe I'm just not particularly good at reading it. I must say, the way it was written was not particularly transparent. I found it a rather disappointing document, actually. But that's just me. New York City. 1% of positive tests. Good, that's down quite a lot. 1,800 schools planning on opening. That's 1 million pupils, or I believe you call them students in the States. They're going to be doing random temperature checks, medical nursing supervision in the schools, 14-day quarantine for positive tests, all good. But there seems to be a battle between the authorities and the teachers' unions. That's the way I read this as an outsider. Teachers want to be cautious and suggest a phased opening, which does sound reasonable to me. And the teachers' union saying there's not enough ventilation. Now, I agree. I talked to several people in Thailand who of course had very low numbers of cases, and they said the first thing they did when they realised this virus was about was they turned off the central heating and they opened all the doors and windows and got as much ventilation as possible. That diluted the viral load. Exactly the right thing to do. But the teachers are saying there's not enough ventilation in New York City schools, and ventilation is going to be massively important. I've been talking about this for months. It's so easy just to open doors and windows, and that's going to reduce the transmission, I believe, by reducing the viral load. So if places can't be well ventilated, then if you've got 1 or 2 infected people, you've got virtually guaranteed transmission. If it's well ventilated or outside, the chances go down quite dramatically. Because remembering the lesson from Georgia, was it Cherokee County, I believe, 80 confirmed cases, now 1,100 quarantined after their reopening. Now, California, the news outlets are saying California is the first state to exceed 600,000. But again, the Centre for Disease Control is not saying that figure. So again, the Centre for Disease Control showing lower figures than the news outlets, who are saying California is 600,000 plus. Yeah. So again, Centre for Disease Control figures with news outlet figures, slight variation there. But, you know, it is showing the great increases in cases in southern states like California, Florida, Texas, these large populated states. Now, moving on to Europe from the United States, just starting off with this graphic, we see that basically cases are increasing in many places in Europe now. So all this here was the original outbreak. This is a logarithmic scale, of course. But now we see all these increasing again. So let's just go in and look. Now these are daily cases. This is not adjusted for population size. So Denmark and Greece, it's the shape of this line you need to look at. I mean, it's so obviously going up, isn't it? We're getting increasing cases in all of these countries now. Denmark and Greece going up. They're down here because they've got relatively low populations. Italy, the direction is up. This one here is Belgium. That seems to be the exception. So that seems to have had a sharp downturn. Netherlands going up. That's Germany. That line there is actually the UK. So the UK and Germany on very similar trajectories there. But there's no question that is an upward trajectory. France, obviously, going up. Spain, likewise, the overall trajectory is going up. So no real doubt there that there's these increasing cases in Europe, and it is sustained. And I think it's reasonable to define a second wave as a sustained increase in cases. And alas, that is now what we are seeing, I believe. So it looks like there is a second wave starting in Europe. And I'm going to give some examples of that now. So Croatia, small former Yugoslavian country, for example, 208 new cases on Friday. Now, this is another pattern. Average age of infected people is 31 in Croatia. Now, what we are seeing in many places in Europe is the increase in cases is amongst younger people, largely because of younger people socialising together. Perfectly understandable, of course. So we see a lot of new cases. But fortunately, so far, we're not seeing a lot of hospitalisations and deaths, because young people are very much less likely to get severe disease. So the amount of people actually being very sick and hospitalised and dying is not increasing in most European countries, because the spread is primarily at the moment in younger people. The risk, of course, is that this will spread it to older people, their parents and grandparents, and that will cause severe disease, hospitalisations and deaths in that demographic. So that's a bit of a trend that we're seeing. And this, of course, is very different to the first wave. Very different to the first wave. So, in a sense, so far, not as serious as the early stages of the first wave, because it's mostly younger people. Now, the Croatian authorities are saying 2/3 were infected in the nightclubs and bars that remain open beyond midnight. Now, this is quite a slick piece of epidemiology. They've worked out not only where most transmissions is, but when most transmissions are. So they've been able to target and say, right, bars are closed after midnight. So that's really quite clever. They've said, look, most transmissions taking place after midnight. You can probably guess some of the reasons why that might be. And they're actually saying, right, okay, close them at midnight. So bars after midnight is the epidemiological driver. Identify that, and that can be rectified at relatively low economic cost. Spain, likewise, ordered nightlife establishments to close, all bars and restaurants all over the country, all shut. Banned drinking on the streets for similar reasons. Young people drinking on the streets, the consequences of drinking, of course. Smoking in public places banned unless there can be at least a 1.5 metre gap. Again, the idea that seems to be prevalent in Europe now is the virus can hitch a ride on smoke particles and be transmitted in that way. It's almost like an aerosolization, isn't it? But it's smoke. And, you know, if you go into a smoky area, the smoke can hang in the air for hours, can't it? And the virus can hang on to those smoke particles. So, in my mind, 1.5 meters is not enough. You can still smell cigarettes 1.5 meters away. But it's better than nothing. And, of course, anyone who smokes when anyone else can breathe in the smoke is being grossly inconsiderate at the best of times, and even more so if there's the potential for viral particles to be associated with those particles of smoke. Advised against gathering more than 10 people, specifically warn young people not to gather outside to drink. So again, transmission driver has been identified, young people drinking outside, so that can be acted on much more specifically, as that is the particular infection driver. It's where the transmission is going on. Belgium has suffered quite badly in this pandemic, in the first wave. Face masks now compulsory in public places. Hospitals are stockpiling drugs and protective kits. So there's obviously some concern, enough to last for 2 or 3 months during any second wave that may arise. Now, this is probably partly once bitten, twice shy, because the Belgian authorities were caught on the hop in the first wave. So they're making sure that doesn't happen again, and they're stocking up. But it also shows that there is a realistic fear in Belgium that there will be a significant second wave, presumably amongst middle-aged and older people, that will result in hospitalisations requiring the drugs to be used and the protective kit to be used. France, record number of cases in 24 hours, 2,846. Sharpest rise in 25 to 35-year-olds again. Less than 5,000 hospitalised, only 136 in the whole country in intensive care. Now on the 8th of April, in France, there was 8th of April on France, there were 7,148 people in intensive care in France. Now there is 136 COVID-related cases, of course. So there's currently 136 COVID-related cases in intensive care in France. There was 7,148. So hospitalisations not increasing because most of the new infections are in 25 to 35-year-olds. Now, tragically, a few of these will get severe illness. There could be a few deaths. Some could be left with long-term sequelae. But basically, these are not getting acutely ill at the moment because they're younger people as we know, are less severely affected. So this is the pattern we're seeing all over Europe at the moment. Deaths went up by 18 on Friday compared to 17 over the last 2 days. So 17 deaths, 18 deaths. Relatively modest increase in deaths in France. And even that's not surprising considering those people in intensive care. Paris and Marseille are considered to be high-risk zones. Now, the United Kingdom didn't check on the new number of cases. Should have done, forgot to fill that out. It's about 41,000 now, isn't it? Maybe just over. Based on the new way of accounting for it, as we'll check in a minute. Now, this was interesting. So the new cases in 24 hours, according to the Office for National Statistics, was 1,441. According to my COVID symptom tracker app, it was 1,434. Very close, isn't it? I think this app must be getting a lot better. It's getting quite finely tuned now. That is impressive. But it's still the highest rate since the 14th of June. So there is a pickup in cases in the UK, as indeed we saw on that graph at the start of this European section. Deaths 11, and these are deaths that died within 28 days of testing positive. So that's the new way of doing it. So deaths within 28 days of a positive test. So that's the new way that deaths are recorded now. And as we know, that's about 41,000 from memory because I didn't write it down. Now, deaths where COVID-19 is actually recorded on the death certificate from the Office for National Statistics are higher than this, of course, quite a lot higher than this. But these are the ones that have had a positive test and then died within 28 days of being tested. So really that's the minimum number of deaths in the UK that they're recording via that methodology. But they're open about it, so that's okay. Now, a lot of people were very annoyed about this because France, Netherlands and Malta, the UK has now instigated, with about 24-hour notice, a 14-day quarantine for returnees from about 8 hours ago, 10 hours ago or something. So early Saturday morning. So what happened here was the British government noticed increasing cases in the Netherlands, Malta and France. So they said, well, our citizens who are there now, as from 3 a.m. on Saturday morning, the morning just gone, well, you've got to quarantine for 14 days if you get back. So what happened was there was this massive rush to get back to avoid the quarantine. Now, it kind of defeats the whole object, doesn't it? Because the whole point of the quarantine is to identify people who may have been infected. But all these people have rushed back, and some of them are going to be infected, but they don't have to quarantine because it's not a legal requirement to do so. You know, what's the difference between someone coming back at 2 o'clock on Saturday morning and 5 o'clock on Saturday morning? The 5 o'clock on Saturday morning is legally obliged to quarantine for 14 days. The other one's not. But the risk of having the disease is pretty well the same. Now, we saw this in the early stages of the pandemic in China, people going out of Wuhan to avoid the quarantine. And there was a big rush when they knew the quarantine was coming. Well, we've seen the same situation here. And this is probably part of the reason why the government is giving a low amount of notice to particularly avoid this behaviour. We saw the same with the lockdown in Manchester, where it made sense to give a reasonably short amount of notice so that people couldn't be travelling back and forward, spreading the disease before the quarantine deadline. Anyway, there's 160,000 Brits were in France at the time. Now, Spain, we've had a 14-day quarantine since the 26th of July. So if you're going from Spain to the UK, you've got to quarantine for 24 days. And the UK has now ordered a total of 6 different vaccines. We ordered 1 or 2 new ones yesterday, hedging our bets on all the vaccines, as indeed are the United States. The concern is that with the UK and the US and other European countries like the European Union putting dabs on these vaccines, there might not be enough left for poor areas of the world. Putting dabs on is a kind of an English way of saying making special reservations for, I guess. Now, the Office for National Statistics Week ending the 31st of July, 193, that's 2.2% of all deaths that week involved COVID-19. Way down on what it was. Between the 5th and the 9th of August, 67% of adults in the UK are worried about the effects of the pandemic on themselves and their families. 3rd to the 9th of August, 28,000 people in the community in England and Wales had COVID-19. That's 0.05% of the community population. So that was the number of active cases in this week. 28,300 active cases in the week 3rd to the 9th of August. That is not including people in hospital, that is not including people in prisons, not including people in any institutional setting like a care home, for example. That equates to 1 in 1,900 people at the moment, but as we know, it's slightly increasing. 0.6 new COVID-19 infections for every 10,000 people in the community population in England. Just another way of saying the same thing in different ways of expressing it. And that equates to, in that time period, 3,800 new cases per day. That's as of the 3rd to the 9th of August. There was 3,800 new cases per day in the UK. Now, the antibody surveys in the UK carried out by the ONS are very interesting. As of the 9th of August, the cumulative antibody test was 6.2% of people aged 16 and over positive for the antibody. Now, we know that these antibodies don't last for long, but this is cumulative antibody data. So there could have been someone who was tested for antibodies 6 weeks ago who was antibody positive for COVID-19 antibodies. But if you tested them today, they might be negative because the amount of antibodies have dwindled. But they're still counted as having COVID-19. So these cumulative antibody tests are probably the most accurate way we've got of tracking the infection. So this looks like 6.2% of the population now where is this? Is this England or the UK? I think this is just England. 6.2% of people in England have had the infection. That equates to 1 in 16 people in England. London was the highest. That's 2.8 million people have been infected in England, and that's a definite figure because that's based on the antibody testing. And the reason I'm saying it's a definite figure is the Office for National Statistics is well capable of doing a representative sample and extrapolating up to the entire population of the UK. That's what they do. They are very good at it. Now, briefly, India, cases increasing. 60,000 new cases a day for the last 3 days, and it's spreading from the cities to rural areas. And you get the impression there's a bit of an iceberg in India. So, for example, one jail in Kashmir, 102 of the 480 prisoners were tested positive. And I suspect this is repeated in other areas that we don't hear about. So that's what I wanted to talk about in terms of the update. Now, here's the data about the Africa situation. I'll post it, of course, and you can peruse it for yourself. Just a few ideas. It's kind of thinking out loud, really. We know the demographics younger in Africa, but we also know even when that was accounted for, in one study there was 8 times less cases than would be expected. So have they been exposed to other coronaviruses in Africa that haven't been identified by virologists and are giving cross immunity? It's possible. Is malaria and other infectious diseases priming the immune system? That's possible. Now, this next one's interesting. I've put genetic diversity. Just let you see that. Genetic diversity and Neanderthal genes. Now, this is... Some of you might be bored stiff by this stage. If you are, I hope you've got the main points of the news, but I find this fascinating. Now, all of the models indicate that humanity originated in Africa, migrated out to the Middle East and onto the rest of the world. So what this means is that the human populations in Africa have been where they are for much longer than in other parts of the world. So there's been more time for genetic variation to develop. So as we said yesterday, there could be 2 African groups on either side of a mountain range that could be genetically more different than I am from Chinese. So there's a lot of genetic diversity, which may account for some of the potentially improved immunity in Africa. And the other fascinating one is Neanderthal genes. Now, I'm about 2 to 3% Neanderthal. Everyone out of sub-Saharan Africa is. So if you are an American indigenous person, then you're 2%, 3% Neanderthal. If you're Russian or Chinese, you're 2 to 3% Neanderthal. Even if you're Aboriginal Australian, you've got Neanderthal genes. But sub-Saharan Africans don't. So there is this genetic difference that we are part Neanderthal, sub-Saharan Africans aren't. And the reason it could be significant is some of the Neanderthal genes that are in modern humans have been associated with immunity. That's perhaps why they've been preserved for all these thousands of years, because Neanderthals died out about 30,000 years ago. So this interbreeding between us and Neanderthals took place a long time ago, and the Neanderthal genes that have been preserved would have an adaptive advantage, and some of those are related to immunity. So nothing can hang your hat on there, but interesting. Gastrointestinal parasites are much more common in Africa. Now, what these do, gastrointestinal parasites can act as an immunomodulator. So, for example, people with autoimmune disease have been documented. There's not a lot of experimental evidence, but it can reduce the severity of some autoimmune diseases. But by having gastrointestinal parasites, worms, but basically worms, flatworms, roundworms, hookworms. The presence of these parasites means that people sometimes don't have an abnormal immunological reaction. Now, of course, we have lived with parasites for tens of thousands of years. And all of a sudden, in your nice clean house with your nice clean antiseptics, you don't have parasites. In fact, if you're watching me in Europe or the United States, the idea of having a worm in your intestines probably appalls you. And yet it is the natural human condition, it would appear. Has been so for tens of thousands of years and still is in many parts of Africa. So are these having an immunomodulating effect which would prevent the extreme inflammatory reactions associated with acute respiratory distress syndrome? Again, exposure to animals, animal bugs, diet, high plant diet. Now, the high plant diet, where are we? Yeah. That's interesting, the high plant diet, because the fibre in the high plant diet is good for the microbiome or the friendly bacteria. Because where have I gone? There we are. Because the fibre acts as what you call prebiotics. The good bacteria feed on it, and that can have immunological effects as well. It's good for you for all sorts of reasons. So high plant diet means you've got plenty of prebiotics that give the microbiome lots of nice food to eat and gives you a very healthy microbiome. And it is known that the microbiome, all these bacteria in the small intestine, we do know that it's very much more diverse in a lot of African populations. So the healthiest, most diverse microbiomes in terms of population distribution are in Africa. In a fairly basic African situation, people you could argue, are living close to the original hunter-gatherer idea, and their microbiomes are much more diverse than many of us who live in Western countries, who have a much more homogeneous diet, often not based so much on plants. Someone once said that all you need to know about diet is eat plants. Eat food, not too much, mostly plants. We'll go into that on another video. It can be discussed. So the high fibre diet will give lots of prebiotics. Probiotics are the bacteria themselves present in the diet. But bad diet, such as eating a lot of highly processed food, processed meat and processed carbohydrates, that could have an immunosuppressing effect, and it could make inflammatory reactions more likely to occur. Vitamin D from the sunlight, of course, is almost certainly a factor. in many African groups. Even though the skin is dark, many of them spend much more time in the sun than we do. Question mark over various commonly taken drugs. Don't have any data on that, but I'm open to that. Obesity is a problem in the West, perhaps more so than in Africa, and physical fitness, or the lack thereof, is a problem in Western countries. So there's a few ideas. I'll paste those there, and you can send me others in. We're collecting a few. That's good. Well done on that. Now, just before we finish, there's this bizarre rumour going around. Let's do my temperature actually. This bizarre rumour going around that these things can do some harm. Well, I've been using them since they were invented, and I'm quite warm. There you go. You've warmed me up. 37.2. It is quite warm in here. Let's try again. 36.8. Okay. So my temperature is about 37, which of course is absolutely fine. And this is my own thermometer, so I can use it. I can put it in my ear as well. If you're using a shared one, we have to have covers. Yeah, about the same, 36.7. Now the thing, what these thermometers are doing is they're not emitting anything. Now this thing does. Let me just put this on the overhead. This one is giving out a laser light. Going through my finger to register the difference between my hemoglobin, oxyhemoglobin and deoxyhemoglobin. Do you see what you've done to me? You've put my heart rate up to 85. Must be a stressful situation. 83. Oxygen saturation's at 95. Heart rate's coming down a bit now. Because I'm trying to relax. 77. That's the trouble with these physiological observation things. You become obsessed with them. They're just so interesting. But the point I'm trying to make is these aren't giving anything out. Let me take your temperature, look. Let me take your temperature. I'll turn on my machine. Do you see any lights coming out of this when I take your temperature? So there you go. I've taken your temperature now, and it says 33.4. Now, of course, that's not your temperature. It's the temperature of the camera lens. But the point I'm making is this is not chucking anything out. It's just a receptor. 32.4. Must be warm in here. My temperature, my camera lens is warm. So these things aren't giving out radiation. So any idea that these things are a risk is just ludicrous. They are detectors. They're detecting what's there already. Now, some of you will want to finish this video now, but if you don't, I'm just going to tell you briefly what's going on with these things. They're measuring infrared radiation. This is called black body radiation. Now, what happens is that everything with temperature has a kinetic movement. There's movement. When you go down to minus 273 degrees centigrade, there's no movement. Anything beyond absolute 0 degrees Kelvin, there's movement. And the more movement, the more infrared it gives off. That's called black body radiation. That's why scientists can measure the pressure of stars and planets and stuff all over the galaxy and stuff. Now, infrared is what we call non-ionizing radiation. Insufficient energy to completely remove electrons from atoms. So infrared, these things aren't giving off anything as far as I know, but even if they were, infrared that's coming off hot bodies is not ionizing. So visible light, infrared, microwaves, radio waves, non-ionizing. Ionizing radiation is the dangerous one. Enough energy to remove tightly bonded electrons from atoms, thus generating charged ions. You might remember from chemistry, an ion is a charged atom. Of course, it's no longer an atom, it's now an ion. So X-rays, gamma rays, good to avoid. Ultraviolet radiation is intermediate between these two broad ranges. But we know ultraviolet radiation can cause malignant changes in the skin. And click on the FDA for full details. Food and Drug Administration. Good. Well, that was a bit of a long video today. If you're still here, thank you. I appreciate you watching. I know it is. It tends. I've done look at the demographics on YouTube. It does tend to be the same people that watch these videos most days. So I do appreciate you sticking with them. And I'm still finding it. I'm still finding it interesting. And hopefully you are. I think we're learning a lot about this pandemic, but we're also learning a lot about our own health and the health of our families. And a better understanding of human health, I believe, can only help human health.